I'm now going to do a focused exam on the ears. We'll examine the external ear, the external acoustic meatus, show you how to examine the tympanic membrane, and then evaluate hearing and labyrinthine function, the two major functions of the ear. So to examine the external ear, we want to look at the ear both anterior and posteriorly. We'll do that on both sides. Move. And from straight on to look at symmetry of the ears. We'll now try to examine the tympanic membranes and the external meatus. This is done with the otoscope. The otoscope should be relaxed in your hand. Take the tension off the cord, which is quite important, so that in this hand you're quite comfortable. It can be held in this position. Always anchor the otoscope against the head so that if the patient moves, you move with him. It can also be done in this position, but either way you're anchored against the head. The external acoustic meatus runs anteriorly and superiorly in the direction of the speculum. So to straighten the cartilaginous canal, you grasp the ear, pull up and back gently, and that straightens the cartilaginous portion of the canal and allows for a more clear view of the tympanic membrane. When you insert the speculum, if you push it gently against the tragus, this will also help you to be in alignment with the canal and decrease discomfort for the patient. When you inspect the tympanic membrane, you should be able to see the ossicles. Identify the light reflex. Look for any fluid, thickening, bubbling, and of course examine the external canal itself. Exostoses in the external canal are common. In children, it's remarkable what you can find in the way of foreign bodies. So now I'm going to examine the left ear, and I'm going to demonstrate using the otoscope in this position. Notice that once again I've taken the tension off the cord so that the otoscope itself is relaxed in my hand. Once again, we're going to try to straighten the canal, grasping the ear, pulling up and back, moving the tragus slightly forward with the speculum, and then advancing into the external meatus. Looking at a very normal translucent drum, normal light reflex, and normal ossicles, which can be easily identified. And then slowly pull it out, examining the external canal. So that's a nice atraumatic examination of the ear. I'm now going to check hearing. There are four methods that I use to check hearing. First, of course, is during the interview. You can tell whether the patient can understand normal fluent speech in a quiet room. If they have trouble with that, then it's virtually certain that they have a significant problem with hearing loss. But many people with significant hearing loss are able in a quiet room to understand normal speech. So the three methods we use in addition in the office setting are finger rub. You hear that?
Yes.
Hear that?
Yes.
Is it the same or different?
It's the same.
Okay. So that's finger rub. You compare the two sides. Second is whispered speech. 1, 2, 3. Able to hear me? What did I say?
1, 2, 3.
Okay, good. And the third is to use a tuning fork. The most important frequencies for speech hearing are between 500 and 2000 hertz. And a 512 tuning fork is very good to use to check the hearing. And again, we're going to compare right to left and then compare his hearing to my hearing. Able to hear that? Hear it here? Any difference between the two ears?
No.
Now, tell me when this disappears.
No.
You hear it there?
Mm-hmm.
Tell me when that disappears.
No.
Okay. All right, so it seems to have maybe a little bit of hearing decreased on the left compared to the right. I could hear the tuning fork when he couldn't hear it in either ear, so maybe a subtle hearing loss. The next thing we want to know, if there is any question about hearing, is it a conductive hearing loss? In other words, a problem of getting the message from the air into the cochlea, or is a problem with the actual cochlear nerve function of the ear? One way to assess that is to compare air conduction to bone conduction. To do that, we place the tuning fork on the bone and then in front of the ear. Is it louder here or here?
Second.
Second. So that demonstrates that air conduction is louder than bone conduction, which is normal since the ossicles actually amplify sound. Louder here or here?
Second.
Second. So air conduction is greater than bone conduction on both sides. Then we can compare bone conduction from one side to the other, and we do that by placing a 256 tuning fork in the middle of the head and asking them if it's louder in one ear than the other. Do you hear that? Louder in one ear than the other?
Sounds the same.
Sounds the same. So it's right in the middle when you hear? Okay. So that indicates, despite our first suggestion that there might be some imbalance in the ear, that the neural aspect of hearing is balanced. So probably normal hearing. Beyond this, we would have to do an audiogram to really sort out if there's any significant hearing defect, but this appears to be normal. Now, the second function of the ear is balance through the labyrinth, and we'll now check the labyrinth by doing a Romberg test or stance. So we'll have the patient stand with his back here towards the wall and position with the feet together and with the eyes closed. Be sure to be in a position to catch the patient should they lose their balance, particularly in older people. They can certainly injure themselves. So shut your eyes. How do you feel there?
Fine.
Okay, notice also that he's not making any movements to save his balance. He's not jerking or wiggling or lifting his arms from the side. Next, I will push him forward to the side and backwards to see if he can maintain his balance, which he does. So this is very good labyrinthine function. Last, we'll do a provocative maneuver for labyrinthine function to check for the presence of what we call benign paroxysmal positional vertigo. This is the Hallpike-Dix maneuver. We're now going to do a provocative maneuver of the labyrinth called the Hallpike-Dix or Dix-Hallpike maneuver, depending upon your preference. This is a test we do frequently in people who we suspect the condition of benign paroxysmal positional vertigo, where an otolith or small piece of calcium is migrated out of the utricle into a semicircular canal, usually the horizontal canal. To do this, we remove the pillow and have the patient scoot back on the table. He's going to have to be back far enough that when he lies down, his head will extend over the end of the bed. We then raise the chin, turn to the right side to begin with, and then we'll rapidly lay him back, supporting the head, and watch his eyes as he keeps his eyes open and looks straight ahead in his axis of vision. So let's go down backwards. Okay, straight ahead. And you examine the eyes, and if there's nystagmus, or rapid beating of the eyes, is an abnormal response. It's important to hold this position for up to 30 seconds as the response may be delayed. If they develop nystagmus, it can oftentimes be accompanied by very severe nausea. That should forewarn the patient that they might be very uncomfortable with this. Okay, and then we'll sit him back up, eyes open, straight ahead, and continue to look at the eyes, as occasionally people will show the nystagmus when they sit again, having not had it when they lay down. Give him some time to re-equilibrate, and then we repeat it with the chin turned to the other side to test the opposite semicircular canal. You okay?
Mm-hmm.
So now we'll raise the chin again, turn a little bit to the left, and once again go down. Hold that position straight ahead, eyes straight ahead, straight ahead. And we certainly don't see any nystagmus here. And then we'll sit him gently back up, and again continue to observe the eyes straight forward. And that's a normal response. So Hallpike-Dix or Dix-Hallpike maneuver to check for benign paroxysmal positional vertigo. And that completes the labyrinthine exam.